going to transition to practicing and learning soft tissue techniques, connective tissue techniques for the ankle and foot. The indication for these techniques and also supporting interventions. All right, either lie down or you can long sit, whichever one you prefer. What we're going to do is dorsal plantar sweep. So the dorsal plantar sweep, it stretches the syndesmosis between the metatarsals or metatarsal heads. So when we talk about syndesmosis, what are we talking about? So when we talk about syndesmosis, we're talking about connective tissue that connects osseous structures in a sense. So in between each metatarsal, there's going to be what they call a syndesmosis. It's just connective tissue joining each or connecting each metatarsal, okay, and metatarsal head. So there's a way that we can stretch the syndesmosis by performing what we call a dorsal or plantar sweep. Okay, so these are considered joint play motions that are necessary for functional gait, because when we walk, you have either a dorsal sweep or a plantar sweep occurring when we ambulate. Okay, so it's joint play that's necessary for functional gait. So let's start with I'm gonna start with the dorsal sweep. So with the dorsal sweep, what I want to do, I'm going to take my thumb and I'm going to contact her fourth metatarsal with my right thumb. Come back and I'm going to come back and contact her second metatarsal with my left thumb, and I'm going to actually try to bunch up the skin. I'm going to attempt to bunch up the skin. So my index finger is also contacting the plantar aspect of the fourth metatarsal, and my second index finger is coming around hooking in on the second metatarsal. And what I'm gonna do by performing a dorsal sweep, I'm gonna make an outward motion with my thumbs. So I'm stretching the dorsal aspect of the syndesmosis. So I'm making this movement right here. This is the movement that I'm making, outward movement like this. So dorsal sweep. So I'm making the dorsal aspect, more convex. Does that make sense? So as I'm making a dorsal aspect bunch up the skin, as I'm making a dorsal aspect more convex, what is happening to the plantar aspect? It's becoming more concave. All right? Does that make sense? All right? So now the syndesmosis, the dorsal sweep, I have a stretch of the syndesmosis dorsally. I want to stretch the syndesmosis or connective tissue from the plantar aspect. So I'm just going to do the opposite. So now, bunch up the skin as much as I can. Again, my left thumb is now contacting the plantar aspect of the fourth metatarsal, and my right thumb, and you can play around with this. My right thumb is on the lateral aspect of the first metatarsal, or I can bring it to be exactly on the second metatarsal. Okay, so either or. And now apply my stretch, my plantar sweep, and now I'm stretching out the syndesmosis, the plantar aspect of the syndesmosis. So now my hand are making this movement right here. You see that? So now, what is happening with the plantar aspect? The plantar surface is becoming more wet. Convex. Now the dorsal surface is becoming more wet. Concave. So now, if you think about it, when you walk, right? So let's think about walk. I'm walking, I'm in terminal stance, all right? Terminal stance, transitioning pre-swing. So now, terminal stance, transitioning to pre-swing. What is my plantar aspect doing? More convex. So if you're thinking about it, it becomes more convex, all right? So if it becomes more convex, then your plantar sweep is gonna be more beneficial for terminal stance, pre-swing. Whereas your dorsal sweep may be more beneficial for initial contact. You see? You see that? I see you say yeah. So this in the instance of knowing how you can utilize these two to improve what? Like what am I aiming to improve? What is my patient lacking? So you may have a patient who's lacking plantar flexion, doing terminal stance, pre-swing, and so lacking what they call push off, right? And so this could be a beneficial technique that if they're just stowed up and tight in the foot, this could be a technique that could be beneficial, that you can use this technique and then you can follow this technique with some supported intervention, okay? With this technique, I'm not blocking anything or stabilizing anything specifically in this area. So you can either use a wedge or not use a wedge. It's up to you. I just put that in the picture as an option. I've probably done some talocrural joint molds, and I just leave the person on a wedge and transition to maybe doing some work at the foot. So for example, if I've done some joint molds, and I say I've done something to improve plantar flexion. So say I've done an anterior glide of the talus on the tib field to improve plantar flexion. I may have started out on the wedge because now I'm gonna go, I already have the person on the wedge. And so now I'm gonna go down to the foot. I'm just gonna leave them there and I may do some flexor-hallucis stretching. You see, I may come and do some dorsal and plantar sweeps and I just end up leaving them on the wedge. To stretch the popliteus muscle, you want to get the patient, make sure that they're in extension, all right? So make sure that the hip is in neutral, aligned, good. You got good alignment. You want the knee to be in extension. So what I want to do to stretch the popliteus muscle is with the knee in extension, I want to internally, so I want to prevent her femur from moving. I'm going to kind of use this hand here to stabilize and just internally rotate the tibia. And I can hold it. Okay. There we go. So I like this hand placement better. So I'm letting my thumb, I'm using my web to stabilize her femur so that her femur doesn't move, and I want to rotate the tibia internally on the femur. I can come right here. As she's extended, fully extended at the knee. You feel that stretch? Okay. I can progress it and take her, I can take her and try to progress her to as much internal rotation as I can get. Hold it for 30 seconds stretch. I can incorporate hold, relax, contract, relax with that. So let me show you how that looks. Okay. So hold, relax. I haven't even taken her into internal rotation yet. So I'm gonna try, I want you to hold this position and don't let me move you. So what am I trying to do with hold, relax? So I'm having her holding this position, don't let me move you. What am I trying to move her tibia into?
Your resistance in the opposite direction.
There we go. Good job, Tia. So hold this position. Don't let me move you. So I'm trying to move her tibia into external rotation. She's holding that. Now relax for me. Now I'm gonna take the tibia into internal rotation. And now I can hold it for 20 to 30 seconds or however long I want to hold it to get a stretch there. Okay. Muscle function. What is the muscle action of the popliteus muscle? So flexion and internal rotation. So how does it unlock knee? So remember, you stretch this muscle by maintaining extension with internal rotation of the tibia. All right. With Stanley Paris, he did a lot of dissection of cadavers. And what he would notice was that there were variations in patients with certain origins and insertions of muscles. Like the sternocleidomastoid is one that they identified that had attachments at the occipital condyle, occipital lobe. So Captain Patler called it scum. So this is a muscle that Stanley Paris found to have attachments at the fibula head. And so to maintain and get a great stretch on it, since it was at the fibula head, then you stretch it greater with internal rotation. So that's pertaining to this technique, but we know textbook, we know the muscle actions of the popliteus is flexion, internal rotation of the tibia, right?
The extension's key. I think if you were trying to stretch it for flexion, internal rotation, you're not going to get the stretch. If you take them past that point to full extension, and it may even be something kind of like piriformis muscle, where varying degrees of hip. Yeah, I can't tell you that for sure, but in my mind, that's what I feel like it is. So it's worth a little more investigation.
I would assess the popliteus muscle in the case where someone may come and say, man, when I fully straighten my knee, it's challenging for me to bend my knee initially. I have a tough time bending my knee initially, but once I get it bent to a certain point, there's no problem. So they have a problem with bending their knee initially from full extension. That's the function of the popliteus muscle, right? So it unlocks the knee so that the person can then flex the knee. So it's a knee flexor and internal rotator, right? So it reverses the screw-home mechanism. So someone gets fully extended, right? It requires the screw-home mechanism for that. But what if they have a problem coming out of that full knee extension and initiating flexion? That is when I would assess if they come to my clinic and report that, because you don't know what kind of patient is going to land in your clinic. You don't know what type of patient is going to land on your caseload, okay? But some patients can come with knee problems and say that they can describe that as the knee problem that they're having. So now as a physical therapist, you have to know, okay, what problem could that be that I need to investigate? So it could be that they have a tight popliteus muscle that needs to be stretched.
If you don't know this, the popliteus muscle also has attachment into the lateral meniscus. And so when it contracts, you can fact check me, look into this a little bit more, but it also helps to pull the lateral meniscus posteriorly so that you don't get it doesn't become entrapped between the femur and the tibia as we move into flexion. Okay, so look at that as well. You'll see that where it attaches, I believe it's between the lateral meniscus and the LCL, but there's some relationship there that's probably significant clinically between the popliteus and the lateral meniscus.
Very important muscle. Very, very significant muscle that we need to be assessing. The flexor hallucis longus muscle. So what does the flexor hallucis longus muscle do? All right, so we say it flexes the big toe, right? All right, so since it flexes the big toe, how does it have to be able to contract to flex the big toe? concentrically, all right? So now, if I want to extend a big toe, how does it have to be able to contract? Eccentrically. So eccentric contraction is an elongation. So the muscle elongates with the eccentric contraction, right? So what movement at the hallux would demand eccentric contraction of the flexor hallucis longus? MTP extension, which is very important for gait. When is MTP extension required or demanded during gait?
Push off.
Okay, push off. Great job. We need to know that because many of your patients are gonna lack that because they lack MTP extension. How much MTP extension is required for adequate push off?
60?
Okay, around about 60 to 70 degrees. All right, y'all in the ballpark. So good. So this is something we want to assess and treat if necessary. All right. So what I'm going to do, come here like so. I'm going to just take one of my hands and just hold her heel in my hand. All right. So make sure her foot, ankle is in a neutral position. All right. So what I mean neutral, not access to the dorsiflex, not access to the plantar flex. So in a good neutral position. I'm going to take my index and thumb, all right, and I'm going to extend her at the MTP. All right. Now I'm getting a feel for the resistance of the amount of resistance of her flexor hallucis longus and the infield as well. And so I'm just going to compare for information's sake. Okay, what am I doing? I'm aligning my stationary arm up with the medial aspect of the first metatarsal. So along the midline of the medial aspect of the first metatarsal, then my fulcrum is over the MTP joint, and now my mover arm is over the phalanx. Midline, medial aspect, midline of the first phalanx. Now, I'm in position, I'm gonna put this right here, stabilize it. Now I'm in position to follow the toe throughout the range of motion. So go ahead and move this toe back towards you. Let's see what we get. 0 to 23 degrees. Got a little bit more. 0 to 23 degrees. 0 to 30 degrees. Okay. So with this, with both, this one was still had greater range of motion, right? Mm-hmm. And this one still had less range of motion. But I would deem this as a problem, and I would do the flexor hallucis elongation stretch with this one, although she could benefit from both. Now, get a feel, get your patient in neutral, get a feel by extending at the metatarsal phalangeal joint, moving your patient into extension. Now, there's another option. If you want to make it a treatment, right? By flexing at the MTP, you can try to localize the flexor hallucis longus tendon. So push down, and you feel my hand right here, my finger right here. Push down into my finger for me. Keep pushing. Okay, and relax. So you can incorporate as you extend the MTP of the first hallux, you can incorporate mobilizing the tendon medial and lateral as a treatment to help improve the extensibility of the flexor hallucis longus muscle and tendon while stretching it, okay? But very significant for gait. Your patient has to have that. They have gout, but along with maybe some soft tissue work, along with some joint mold work, and along with doing flexor hallucis longus stretch as well, you may see some improvements and decrease with pain and overall improvements with function if they come reporting something like gout, you know, and give them some supporting interventions that they can do to help resolve things. Go ahead and turn on your stomach for me. We try to do 2 techniques at a time. So this technique right here, right? Someone with tight gastrocsoleus complex, tight Achilles tendons. This would be someone who may have an equinus gait. What does that mean? And walk on their toes, right? Someone who cannot achieve full ankle dorsiflexion, which we know is required for functional gait. And there are many ways you can assess this. You can assess it with goniometry, or you can assess it functionally. Some people you can just have them go into the squat. And if their heels raised with the squat, what does that mean? Yeah, like gastroc Achilles. So there's a quick screen to where you can identify if this is a problem. Now some people may have, you could get some who have Achilles tendon repair. This is, if you have a patient with an Achilles tendon repair, you want to hold off on doing this technique until they are full weight bearing. So that's a precaution. So, and you want to wait till they're full weight bearing before you do this technique if they have like an Achilles tendon repair. But you can do this, but you want to make sure that the doctor has prescribed them full weight bearing. So what does that mean? That means that now once the doctor prescribes them full weight bearing, he believes that the Achilles tendon is now able to maybe handle the stress that it may encounter with a technique like this. So let's recap some things. Load on the Achilles tendon that it can't handle. And so it reaches that failure point because remember, eccentric loading is what? Elongation. So it reaches the failure point and it tears because of the eccentric load is too excessive for the tendon to handle. So that's why most of the time when doing this technique, it's indicated that the person is deemed full weight bearing by the physician. Right? Then you grade this technique. You can use it, but you want to grade it as you perform this technique. So this can be used as an assessment for evaluation and treatment. So I tried to get in, I'm gonna get in right here. So I can feel her Achilles tendon. Most of us, we're gonna be able to feel our patient's Achilles tendon. And so I get in on it and I just do a transverse manipulation. And what I do, I move the tendon laterally, okay? So I go up and down the tendon, assessing the lateral mobility of the tendon, all right? Then I can also assess the medial. So she doesn't get as much medial as she gets lateral. Can you feel the difference, Devonna? Okay. So now that's my assessment, but now I can turn it to a treatment by mobilizing the Achilles tendon in the medial direction and leaving it there. So mobilize it, transverse manipulation of it, or transverse mobility of it, and I can hold it there, and that particular point or region of the Achilles tendon, I can hold it there for 30, 45 seconds, however long I want to hold it there. And I can work my way up and down, finding taut points, like this right here is a taut point, and I get it to its plastic range. Keep it there for 30 to 45 seconds. Do the same thing on both sides. So got your medial mobility of the Achilles tendon, and then you got your lateral mobility of it. So you can assess and treat it both ways. All right. Operator feels for symmetry of movement of the entire length, moving in a medial direction and also moving in a lateral direction. So I can compare the medial to lateral on the same extremity. Then I can also compare medial to medial on both extremities and lateral to lateral on both extremities. You see? So now, guess what? On this one, she goes more medial before I feel resistance in this extremity. So she gets a little bit more medial. So now if I were to compare medial to medial, she gets more medial mobility, or she has more medial mobility in this one than she does in this extremity. All right. And you can also get feedback from your patients. They most time can tell you if they feel a difference or not. Now, ooh, fascinating. So with this one, I experienced greater resistance laterally on this one than I do with this one. That's very fascinating. I gotta work for this one, so I have to work harder for this one with the lateral mobility. Why is that? Does anyone know? Why in the world is that? We're on to the tendo Achilles lift technique. This is a simple technique. Again, a technique to improve the extensibility of the Achilles tendon. So we just get in with our thumbs and get in and try to get up underneath the tendon from the medial and lateral aspects. And we're lifting the tendon up, trying to move the tendon posterior. Okay, so I'm getting in on the medial and lateral aspect with my thumbs, trying to get in up underneath the tendon and pushing the tendon posteriorly or towards me, or you could say towards the ceiling, okay, to lift that tendon. Very simple technique, but effective technique, okay? And I can go up the tendon. I tend to start distally and work my way up and lifting the tendon as I go up. So when I get in on the tendon and I lift it, I could try to hold that lift for about 30 seconds before moving on to the next area of the lift. Okay. And I could do this seated or standing, whichever one. If you do a standing, you can raise the plank high enough to keep good body mechanics. So, like so, or you can sit if you want to, just as long as you're comfortable as the therapist. In the video, I'm doing it sitting. Okay. So, either or, pick a choose. Now, with this technique, I'm going to get the plank as low as I can. I told you. So with this one, I'm going to bring her knee into flexion, about 90 degrees of flexion. So the goal of this, I want to assess the extensibility of the posterior tibialis muscle, and I also want to stretch it if it is a problem. Okay, so now we know that the posterior tibialis muscle is a plantar flexor and an inverter when it contracts concentrically. So what we have to do is move it. We have to perform the opposite of those movements to stretch that muscle. So what am I going to do to stretch it? I'm going to evert at the rear foot. So I'm going to evert, and now I got several different techniques I can use. The one that I like to use is I like to place the dorsal aspect of my index finger and some of the other ones along the metatarsal heads and the metatarsals, and I take my thumb and I apply dorsal force through my thumb on the navicular. So come right here, evert, I got my dorsal force applied to my navicular, and I apply a dorsal force through the navicular and also the metatarsals, taking her foot or ankle into dorsiflexion. So this is a tough one because I want to maintain the knee at 90 and then like so. Okay. All right. So I'm feeling for the amount of resistance with maintaining rear foot eversion and amount of resistance I feel as I move, as I apply my dorsal force, right? My dorsal force to the navicular and to her metatarsals. So now her posterior tibialis muscle is being stretched. I'm gonna do the other one so that y'all can see. Breathe. I'm gonna revert. My thumb is on her navicular. I'm applying a dorsal force. So if I had to compare, this one has less mobility, less extensibility than the one on her right. Go back and do this one again. Invert rear foot. So yeah, so she goes into this one with much less resistance. I'm able to get a little bit more with this one, a little bit more stretch. With that one I felt greater resistance, so I'll probably work on this one more if it were a problem and the patient presents with that type of problem. Posterior tibialis muscle is a very important muscle to assess. You can have patients to come in and report pain, localized pain, and gastrocnemius area. They can also report like numbness and tingling in that area. They can report neurological signs and symptoms as well. Because if this muscle is stoved up, it can bog down on nerves. Posterior tibialis nerve can be bogged down on with this muscle if this muscle is taut. So if you get to the medial, so this is the medial head of the gastroc, right? And so you're coming in, and there's a little septum right here. And if you get in on there and get up underneath there, that medial head, and you're getting up underneath the soleus as well, right there. Did you see her jump? Did you see her jump? I'm on it. So I can go in there and do some release techniques and hold that inhibited pressure on that posterior tibialis muscle and try to get her to calm down. So she said it, right? I'm on that muscle.
If you weren't sure, what could you do to confirm it?
Mm-hmm.
What do you think you could do to confirm it? Okay, what does it do?
So,
Jackson doing it.
mm-hmm. Yep. So let's see something. Push into this hand. It pops right into my fingers. You see? Sometimes my fingers slide, and so I don't feel like I have control with that technique. Sometimes she just come in with the thumb like so, and press down on the navicular and the dorsal. Again, my thumb slides. So I like this technique best, where I can capture the metatarsals as well with this to get into dorsiflexion. Anything you do, any variation you do on this, Dr. McClure does this technique too.
So I'll evert, so with this hand, and I like to take the dorsum of my middle phalanx and put it right on the navicular, and then I fan out my thumb over the second through the fourth metatarsal. So I'm here, 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 have a dorsiflexion. Let's see, I use this handhold, navicular, second through fourth metatarsals.
So that's,
And you gotta have eversion and dorsiflexion, and separating the navicular from the metatarsals in order to separate all the origin insertions. It's a lot of points.
mm-hmm.
You can separate them, stretch them off. Shin splints,
Yep.
plantar fasciitis, Achilles tendonitis, check that muscle.
Check that one. Never, ever neglect your palpation exam. It's gonna give you information. And if the patient presents with a nocioceptive stall response, that's what we call it, NSR. If they present with that, and it's a high reactivity, and so I didn't go through this lecture with y'all when we talk about high reactivity, moderate and low reactivity. If it's high reactivity, it's most likely that's a problem. And so you want to decrease the patient's reactivity with the with your palpation and soft tissue work. Dorsal sweep, plantar sweep. So what could be an intervention for the dorsal sweep? So you know the dorsal sweep, we make it a dorsal aspect more convex, okay? Plantar sweep, we make it a plantar aspect more convex.
Maybe like that.
So if I'm right here, right? And so if I'm right here and I'm doing, so look at my, I'm raising up on my metatarsal heads, I'm doing plantar flexion, right? So the convex portion is becoming more wet, more convex. It's becoming more convex. So I do heel raises, all right?
Oh, the dorsal more convex. Okay.
I'm talking about with the plantar sweep, plantar sweep, with the plantar sweep. So I'm on the plantar aspect of the foot like this, and I'm doing a plantar sweep. The plantar sweep, the plantar aspect is becoming more convex. The plantar sweep, my thumbs are on it. I'm talking about it with my thumbs on the plantar aspect. Say the first or second metatarsal and the fourth metatarsal. And I'm sweeping outward. So I'm fanning outward. So the plantar aspect is becoming more convex. The dorsal aspect is becoming more concave. So now if I sit here and I do heel raises, right, on my metatarsal heads, now my plantar aspect is fanning out, it's becoming more convex. So it's mimicking the plantar sweep, right? Okay. So now any type of exercise where I'm doing plantar flexion, sitting or standing, toe walking, anything that produces like plantar flexion with pressure going through the balls of going through my metatarsal heads, then we know that's going to produce a more convexity at the plantar aspect. So you got to be able to visualize that. Now it's best to go through it and feel it as well. It's best to go through and feel it with your feet and feel what's happening when you put pressure through your metatarsal heads. Can you feel what's happening when you put pressure through your metatarsal heads? So typically, hypothetically, on the dorsal aspect, it's minute, but it's becoming more concave. That's for the plantar sweep. Raise up on your toes, stay on your toes. Okay, now walk on your toes. So he starts off on his metatarsal heads and he goes into more plantar flexion, more MTP extension, and as he does that, his plantar aspect, it widens, it becomes more convex, all right? So the dorsal aspect, it becomes more concave. Now, all right, now when we talking about the dorsal sweep, we're talking about the dorsal sweep. Now my thumbs, now some of you all didn't change your hand placement. I mean, that's fine if you didn't change your hand placement, but I like for my thumbs to guide the movement. So I switch my orientation and then I place my thumbs on the aspect that I'm mobilizing, okay? So in your practical, if you don't change, I mean, just really have to explain and verbalize well. But I typically place my thumbs on the aspect that I'm doing the sweep of. So if I'm doing a dorsal sweep, my thumbs are gonna be on the dorsal aspect of the metatarsal. So somewhere on the first or second metatarsal would be one thumb, and somewhere on the fourth metatarsal would be another thumb, and I'm fanning out like so. And I'm using my other fingers to create the concavity on the plantar aspect. I hope what I'm saying is making sense, that you all follow me. So now I'm creating more convexity on the dorsal aspect, okay? So this is something you have to visualize as well. So now I'm taking pressure off my metatarsal heads, and now as I come up into dorsiflexion, right, or extension, MTP extension, what's gonna happen is now I get more of a convexity on the dorsal aspects and more of a concavity on the plantar aspect. But notice, it's not something that's, it may not be on a large scale to where it's noticeable. So it's something that's subtle, but it does occur, all right? Portic interventions following the dorsal sweep could be wet. So we talked about plantar sweep and supporting interventions with gait.
Banded dorsiflexion.
So you say banded dorsiflexion. All right, I can get a band and do banded dorsiflexion. Yeah, what else?
We do the toe grab.
Like with the marbles? Or the towel scrunch.
So I'm thinking about the tower scrunch. Let me visualize that. That make for the dorsal sweep.
Because when you squint your toes, it's
Yeah.
hard enough in there.
Yeah, I can visualize that, because as I'm doing that, I feel like as I scrunch my toes, I feel like my metatarsal heads have to widen. I feel like some convexity is occurring on the dorsal aspect when I do that. So yeah, I can buy that. So basically you're just thinking about movements that mimic the soft tissue technique. Okay? All right? Good. So what is a mobilization technique that you can use to follow a dorsal or either plantar sweep? So we did the dorsal and plantar movements of the metatarsal heads, right? And so of course we could do the plantar movement of the metatarsal head to reinforce that movement with at either of those metatarsals. Does that make sense? So you could choose any of the metatarsals, any one of them, to reproduce that movement dorsally or plantar in a plantar aspect. Typically, the plantar glide of a metatarsal head is going to improve I'm gonna say of the first metatarsal. Say the first metatarsal ray. If I do a plantar glide of the first metatarsal ray, that's helping to improve pronation of the forefoot. Do a plantar glide of even the second metatarsal, that can help to improve pronation of the forefoot. Can you visualize that? This first metatarsal, right? I will stabilize first cuneiform. I will stabilize it on the wedge. So imagine my finger being a wedge. If I do a plantar glide, like so, a plantar glide of the first metatarsal base, then that's gonna help with improving pronation of the forefoot. Same thing, if I come, wedge, put my wedge up under the cuneiforms and block, and I do a plantar glide of the second metatarsal base on the cuneiform, then again, that's to help with pronation of the forefoot. And say I decide to come to the fifth or fourth metatarsal, and I do a plantar glide of the metatarsal base on the cuboid. All right, what would that help with at the forefoot? When we perform a plantar glide on the fourth or fifth metatarsal base or head, then we're gonna get, it's gonna help with producing supination of the forefoot. Now, that's pronation and supination, okay? Now, if I move any of these in a plantar aspect, when we're talking about pronation, when we're talking about plantar flexion, dorsiflexion. So mobilizing all of these in the plantar aspect helps to improve what? At the forefoot. If I try to capture all of them and mobilize all of them at the same time in the plantar direction. What you say, Andrew? Plantar flexion. This is what keeps me in line. The side that I'm sweeping, the side that I'm stretching, that's the side I like to have my thumbs on. Do you do it different, Dr. McClure? That's my preference, to have my thumbs on the side that I'm stretching. Okay? So I'm gonna use Charlie here, right? So if I wanna stretch the dorsal aspect, my thumbs are now on the dorsal aspect. And so you see my fingers, so you actually can see it better than on Charlie than actual a person, because now you can see the osseous structures. So now you can see my thumb on the medial, my right thumb being on the medial aspect of the first metatarsal, and then my left thumb being on the medial aspect of the fourth metatarsal. And my index fingers are coming around hooking on those. And so now I'm moving out like this. Now my thumbs are moving, fanning out, sweeping outward. And so now this is creating a dorsal sweep. So I'm stretching the syndesmosis on the dorsal aspect. So imagine these springs as the syndesmosis. And these springs right here. The springs are elongating, right? They're stretching from the dorsal aspect. Okay? So that'd be the dorsal sweep. So the dorsal aspect is becoming more convex. The plantar aspect is becoming more concave. So when in doubt, when you really want to see it and visualize it, get Charlie. Get Charlie and practice it on Charlie. Then practice it on your classmate. Then practice it on Charlie. Because the more you visualize it, the less you stumble coming into your practical if this is something you get. You know, now my left thumb is going to be on the plantar aspect of the first metatarsal, and I'm going to come around here and try to get my right thumb either on the fourth or fifth metatarsal, and now my sweep is going to look like this. You see that? So now I got a good stretch of the syndesmosis on the plantar aspect. Flexus hallucis longus stretch. All right, so we practice that. What joint mobilization technique would you use to follow that? If there's a case where you have to have the sock off, make sure you take the sock off. You perform the flexus hallucis longus stretch, right? What problem could the patient have had, or in order to, there's a reason why you perform that? Limited MTP extension, right? So this patient had limited MTP extension, so limited push off during gait, right? So now you've done the flexor hallucis longus stretch, you mobilized it, you've done it how it should be done. Now you're going to follow that with joint mold technique to improve the joint mobilization, joint extension at the MTP, right? You got that? Okay. So the joint mold that you would follow is the one that is gonna improve extension. All right, so if you get on a practical and you say if you had the flexoholisis stretch and you perform that for your problem of MTP extension, now your joint mold has to be in alignment with addressing that problem of MTP extension. Does it make sense? I pretty much set up. So this is one where you may want to stand. All right, I would suggest standing if you get this. I would stand, get her to slight extension for the loose pack position. Come here and stabilize, and then I'm gonna go grade 1. All right, first of all, I'm gonna bunch up the skin, and then I'm gonna slightly distract. All right, there I go, grade 1. You see that? Grade 1 is not much at all. You see that? Grade 2, you feel that? All right. Grade 3, you feel that? And I'm gonna go grade 4. That's it. That's grade 4 right there. Anything beyond grade 4, you know, we typically thrust beyond the grade, but that's your grade 4 right there. Okay? And then I can come back up off of that. So now I'm gonna perform oscillations between grade 1 and 2, right? So I'm just gently going back and forth. Patient reported that she has pain, right? She has pain with MTP extension. It's painful. I'm gonna raise this for my biomechanics a little bit. Because I felt like I was bending too much, bending over too far in the trunk. There we go, this is better, all right? And so now, I'm utilizing grade 2, Dr. Carter, because I'm trying to yield neurophysiological effects. One of those effects is abating nociception. Okay? All right? So now, you gotta know the neurophysiological effects so you can verbalize those. All right? You gotta be able to verbalize the grade of the mode that you're performing. Okay? So I may even go, I may say, okay, I got my patient, make sure she's aligned, come here, make sure I'm at the MTP joint, I have her stabilized. Now I'm gonna go grade 4, and I'm gonna oscillate between grades 3 and 4. You feel that difference between grades 1 and 2? So now I'm oscillating between grades 3 and 4. And when I back off, I'm just going back to 3 and 4. 3 and 4, I'm not going all the way back to 2, I'm not going all the way back to 1. I'm oscillating between 3 and 4. You feel that, Contoria? So I'm oscillating between 3 and 4 because I want to yield mechanical effects. All right? So I actually want to improve this patient range of motion with MTP extension. Or I want to snap adhesions. Or I want to change or address positional faults. You know, you just go through those reasonings, reasons for utilizing the effect or trying to yield the effect that you want. Okay. And so make sure that you know all of your neurophysiological effects. Make sure you know all your mechanical effects, because we're going to ask you. Okay. Firing cutaneous receptors, firing mechanoreceptors. You got to know a progression and a regression. So when you good job. So when you do your flashcards for your supporting intervention, make sure you do whatever intervention you do. Make sure you have a progression ready for Dr. McClure and myself, because we're gonna ask you how can you progress that. Then make sure you know a regression, like how can you make it less difficult. Okay. Because we have to know that as PTs. TheraBand. Try to capture the MTP. All right. What I want you to do is move your big toe back towards you. Good. There we go. All right. And just come back to neutral and keep doing that for me. So notice, all of her extensors want to work, right? So, that's all right though, keep working. we working extensor hollosis longus, right? So we're working, so right now with this TheraBand intervention, I am working and come back slowly, control it down, control it. Don't just let it plop back to neutral, control it. There we go. So now I'm working the extensor hollosis longus concentrically, and I'm working the flexor hollosis longus eccentrically. You gotta be able to verbalize that. So I don't wanna send you into the practical cold turkey. So you gotta verbalize how your muscles are contracting when you're doing your supporting intervention. All right, does that make sense? Because what's gonna happen, likely if her flexor hollosis longus has been taught all this time, then the extensor hollosis longus is gonna likely be weak concentrically, and the flexor hollosis longus is gonna be likely weak how? Eccentrically. Good job. All right. That's like one example of going all the way through MTP extension, then an impairment, and going through a treatment like flexor hollosis longus stretch as a manual therapy intervention, MTP extension, mobilization to improve extension. So that would be the dorsal glide, right? Dorsal glide of the hallux on the first metatarsal base or first metatarsal head, and then progressing to a supporting intervention. All right. So now I want to progress this intervention, right? I've done this intervention, you've done it, you're stronger, we've done some other things. So we've done a lot of open chain things. Now I want to do some closed chain activities, right? Face the plank. All right, go ahead and do some heel raises. All right, raising up high as you can. When you get to the top of your heel raise, hold it for about 5 seconds and then slowly lower back down. Okay. So this would be a closed chain supporting intervention. Okay. Because when she raised up on her toes, what is her toe weight doing? As it has to extend. You see, the MTP has to extend. All right. Now you can try to have her. Now you can isolate it. Now this is what I would do with the socks off. But since she's on the floor, we'll see if she can do it with the socks on. Now this is challenging. I want to see if you can raise your toe towards the ceiling and keep your other toes on the ground. So raise your big toe towards the ceiling while keeping your other toes on the ground. All right, do that about 20 times for me. Nice and slow. You gotta always be thinking of what can I do to progress? What can I do if I have to digress? You know, you gotta always be thinking about that, okay? Now, I can even add, I can say, okay, she's better now. She's doing all this well. I'm documenting patient is making excellent progress with the performance of therapeutic exercises, neuromuscular re-education, whatever the case may be. Now, my patient still struggles with balance, with gait. I can throw in a gait belt and say, okay, let's do some walking on our toes. So let's see what you got. Hypothetically, I'm by her with the gait belt. There we go, good. I set up my cone for her to go back and forth. So next thing you know, now this is my patient with gout. I'm just hypothetically saying this is my patient with gout. We get my patient with gout better, right? Now, a lot of things is gonna be self-management and patient education. So that the patient know what to do when it recurs. You're teaching them modalities that they can do at home, certain things that they can do at home, but you also gotta talk to them about nutrition, about reducing alcohol, reducing salt intake, which flares up gout as well, reducing yeast intake, which flares up gout as well. There's a lot of yeast in beer, but also a lot of yeast in bread, you know. So now you gotta know certain things to educate your patient about, because that's gonna be dependent on how often they come back to you and how they manage successfully. But this is just one case, one problem, one impairment, right? Decreased MTP extension. This is a water ball. All right? Kia cannot grasp this water bottle like this, and she cannot hold it like this. She cannot do this. She cannot grasp this water bottle. All right? And she cannot hold it nor drink out of it. All right? With this hand. So she can't, this is where her thumb is, her CMC. She can't get that CMC to move, you know? So, what's that?
Abduction.
This.
Abduction.
Okay, so she can't get enough abduction to get around to grab that water ball. What are you gonna do?
So we're gonna bring her in abduction, right? And then do a stretch.
What are you stretching?
Her abductors are holding her, or tightening.
So what are you doing in the process? So are you attempting to elongate those? You attempted to elongate those,
Her
right? And
abductors.
stretch the adductors.
Right. And then reflexing this MCP.
Okay.
Mm-hmm.
So like Dr. McClure said, the tricky thing with this, remember why I told you, once you got the person into abduction, you don't have to worry about that anymore. You just stabilize and come up with a way to maintain that abduction. Then you gotta flex the MCP to add to that stretch.
Okay.
You see? All right. So just make sure you practice that and figure out a way you can maintain the abduction, but simultaneously flex at the MCP. Okay. So now, where's your joint mode?
We're gonna stabilize.
Stabilize where?
The trapezium.
There you go.
Trapezium. Okay.
And this is what how you're gonna have to be able to verbalize it on the exam, and you gotta fly through it.
Okay. Stabilize the trapezium.
Where is actually moving on the trapezium?
The metacarpal.
Okay, which metacarpal?
The first.
Okay.
Yeah. Okay.
What grade are you gonna perform?
Are you in pain? No pain. We're gonna do 3-4
Okay.
for mechanical benefits.
Okay.
Okay. So, gonna move it. Okay. I think this is good.
All right.
Okay.
So it looked like to me that you're oscillating between 3 and 4.
Mhm.
All right.
Remember, you're trying to mobilize that joint. So you don't want to stabilize the joint if you're trying to move the joint. The joint's got to move. So you got to name what structure are you stabilizing, what structure are you mobilizing. So right. So CMC is where you were targeting your force. So then right, you got it. So you're stabilizing the C, and you're moving the MC. Right. So just remember that.
Yes. Okay. Supportive intervention. I'm gonna wrap it around her MCP. That was good, Kira.
Whoever.
If this is abduction, you got to make sure it's clear to us what you're doing with your supportive intervention when you're using the band. Okay? Around the hand and have the person to move
That makes more sense.
into abduction to make sure it's very straightforward and clear.
Yeah. That makes
So
more
you got a
sense.
concentric contraction of your abductor pollicis muscles, and then you have a eccentric strengthening. If you want the person to go against gravity, you just supinate them. And you can still do it with the band, but have them perform abduction away with gravity acting down as well. So then this is now just knowing how to use the body and position the body to get whatever effects you want to happen.
Yeah.
You could simply start out with the person supinated and active range of motion against gravity as your supporting intervention to start out. And then when we ask you how can you progress that, then you can add the rubber band. Now you started with the band, rubber band, so since you started with the rubber band, and Dr. McClure and I asked you, how can you progress that with something functional, what can you do?
I'll give her a can.
Oh.
Open up and grab this.
Good.
And then let it go.
And some practices have cones that are wide enough to facilitate that. You can put the cones across body and add more activity. Take this cone, grab it, and place it over here. So you put about 10 cones right here and say, place these cones over here, and grab these cones, place them back over here. When I would assess the popliteus muscle and when I would treat it. If the person has difficulty coming out of full knee extension, so they have full knee extension, but they have difficulty with initiating flexion from full knee extension because the popliteus muscle unlocks the knee from full extension.
Emery has problems extending the knee, right? Okay, then I'm gonna look at the hamstrings. If he has a problem with extending his knee, they might be tight and they might be preventing him from going into knee extension. Okay, bring it down. And then I'll just work my way up.
So you see, I can get right here. So see where I'm targeting with my hypothenar and thenar eminence, getting up in here like so, and then that way. But look how much stronger I probably am than you.
You are.
So my elbow starts out flex, right? And now I add extension to the elbow, and now I'm bending it. Do you feel that? You should be able to feel it. And so I can come here, hold that. But generally, that's why I say you were started out, you were doing good, because I saw you right here, like here, but you have figuring out what to do. So just block out the elbow, and then ease up off of it. So see my elbow go back to slight flex. So let's see what you got.
You still gotta get, yeah, come all the way up with it if you can. Still get in line with it, okay?
So I'm gonna stabilize the proximal knee, proximal to his knee. I'm gonna find the separation of his hamstrings and quads. Put my thenar eminence there. And I'm just bringing that.
Look, when you get that, hold it. When you get that, hold it for a little bit. There you go. There you go. Now she's looking. And then just let your hands, just let those fingers relax. Just let them relax. There you go. So you don't feel like you're pinching in on them. There you go. Find your little time frame to hold that bend. Because when you get them to the plexus range, as far as he go, the goal is try to hold it there. You can try to hold it for about 30 seconds if you can. Some people may not be that strong. So if you're not that strong, you can reduce the time and maybe do a little bit, few more reps, you know, of that. But good job. So you chose to do what technique?
Basically bringing his hamstrings like away from his femur, like in a bending motion to work on his extensibility of his hams.
Okay, good. And typically you can see in therapy and in the manual therapy world, they typically can call that a muscle bending technique, but to keep it simple, you can just say transverse manipulation of the hamstring muscle.
Okay, so perfect. That was the long
That's
title.
more, but that was more simple, just transverse manipulation of the hamstring.
So yeah, I performed transverse manipulation of hamstrings
Okay, why did you do that?
to increase his extensibility of his hamstrings in case they were tight and preventing him from going into full knee extension.
Good job.
You gotta look at it
I think
in a
that's
conflict
okay.
position.
So when we're mobilizing the knee joint, make sure that the heels are floating off the edge of the plant, because we don't want to create any unwarranted torsion. So with the anterior glide, you want to make sure you get your entire hand underneath the distal or the proximal aspect of the tibia, but not cross the joint line. Then I can come right here and stabilize the femur, right? And make sure, work it through the skin, and make sure your force is anterior. You see? All right? And then of course y'all gonna have to, I could do it the other way. I can come right here, stabilize, and make sure my force is interior. Like so.
And where did you say exactly your manipulating hand was?
My manipulating hand is the proximal, posterior proximal aspect of the tibia. Just like this. But it's not crossing the joint line, it's just below the joint line. And I'm stabilizing right the femur above the joint line. You see? And now when I go to mobilize, my mobilization is an interior force. Right here, I got them at a grade 4, as far as I can go. All right. So, you just want to make sure when you are doing your joint molds, you really got to go back and practice your joint molds, because you want to make sure that your line of force and your hand placement is not questionable. You also want to make sure your mobilization hand and stabilization hand is not questionable. You want to make sure that it's apparent when Dr. McClure and I looking, that it's apparent what you're seeing and doing is matching up.
So again, I performed the an anterior glide of the tibia on his femoral condyle to help with that knee extension.
So give me an open chain, intervention and a closed chain intervention.
Well, for open chain, I would have him do long arc walk.
Okay.
If I wanted to, I would have him use a band, but if I wanted to regress it, I wouldn't use the band. I would just have him use his body weight, and then to progress it from a band, of course, I could increase the weight.
Let's see how you look. So you always want to practice instructing your patient on how to do something and watching them do it. So when we assess our patient, right, and we take them through the supporting interventions, are we done with our assessment? No, because we're assessing how they perform the intervention as well. You could maybe sit down in the chair with this one, Jacqueline. Drop it just below his joint line. There we go. You can have it just below or just above, but as long as it's not on the joint line.
This is closed chain, and then of course, if you wanted to regress it, no weights. If you wanted to progress it, just increase the weight of the band
Okay.
to give him a little more resistance.